My name is Kevin Sullivan. I'm a doc at Boston Healthcare for the Homeless program on the street team. We've been around since 1985, and our goal is to provide and assure the highest quality care for Boston's homeless men, women, and children. There are a few different types of homelessness and degrees of vulnerability. Most of the folks who are homeless are just transitionally homeless. They have a single episode, short duration, they lost a job, they got a job, they're back and able to pay rent in a relatively stable way. There are folks that are episodically homeless, the marginally housed. They work manual labor, they're living paycheck to paycheck, and sometimes they lose housing, sometimes they're unable to pay the SRO, single room occupancy fees, but they're in and out intermittently. And then about 10% of the homeless are chronically homeless. And these are people who have been homeless consistently, continuously for more than a year, or more than 4 episodes in the last 3 years of a certain duration. Some people wonder about the interaction between trauma and homelessness and kind of how that intersection became so paramount to my understanding of my patients as I started to listen to them. Stories of trauma just over and over again both contributed to and were a result of their homelessness. Sometimes self-inflicted in terms of substance use, sometimes externally inflicted, like getting hit over the head, getting assaulted on the street, or getting sexually assaulted in the case of many women, and some men. This theme of trauma exists throughout the lives of the patients I care for. The data points at the statistics saying that most of the homeless have experienced trauma. So when I'm meeting them for the first time, I just assume that there's trauma. So I might not know the story the first time I meet them, it's not the first thing I ask, but over time it becomes clear that how they interact is sometimes related to their prior traumatic experiences. I incorporate the history of trauma into my care of patients in how I ask them questions, how I approach them, how far I push or encourage or coach them in various things. I tend to ask permission before doing anything. I ask permission before I put my stethoscope on their back to listen to their lungs, because I don't know who might have been whipped by their parent, and that's a very vulnerable place. So prior to any physical exam stuff, I try to ask until I get to know them better and know where their boundaries are. For any personal question, I try to ask permission to ask a personal question, because crossing boundaries is traumatic and can re-trigger those prior experiences so that they might disappear. And even when I try my best, there are still patients, as I'm talking to them, I see their face change. I see their eyes glaze over. They are no longer present with me in the room. I elicited from them a reaction to a prior traumatic event. I was talking to a young man about his back pain, and I started asking questions, and I was aware of his traumatic history, and I knew it was really bad, and I know I'd triggered him before. I was asking permission to ask and asking permission to ask, and he was saying yes, and then as I started asking the question, he disappeared. So even with my best skill that I could use in that moment, I still caused him to dissociate. And so he left for that appointment, and he came back the next week, and we talked about it again, and we got a little bit further in the conversation. So it's required patience, it's required a lot of humility and a lot of questioning. How much do I really need to know in this moment? Can I just meet this person where they are and sit with their pain? So in response to trauma, there's this rewiring of the brain. A routine event can actually cause an activation of that limbic system. People wind up triggered and going into fight or flight responses unpredictably. It might be predictable for them, but as an outsider looking in, unless we understand what's going on with the person, we might not understand why they're doing it. Sometimes when I'm meeting with patients, they have physical pain in that moment, they have an acute medical need, they have something that needs to be addressed that might be life-threatening or life-disabling. In that moment, it's sometimes really hard to find the balance. I don't know some of that internal pain that they bring with them, that they are bringing into their calculus of how do I make a decision in this moment. They bring their ideas of, no, I can't go to the hospital is terrifying, it reminds me of X. Or when I go into the hospital, I lose control, and that loss of control re-triggers me, and then I'm in psychiatric distress in addition to physical distress. And so I'm going to avoid that because that's safety. So I try to meet them wherever they are, and I try to say, hey, this is what I'm worrying about. What enables me to actually have those hard conversations is the relationship that I build with them over time, and that our whole team builds with them over time. One patient might bond to our nurse practitioner better. One person might bond to our case manager better. One person might bond to other docs on the team, the psychiatrist. We build these relationships, and they're complex relationships, but we can use these relationships to have people engage in their own healthcare. Folks who have experienced traumatic events and have developed PTSD from that, they react to it differently. Some people, it's just the flashbacks, it's just the nightmares. But that by itself is still distressing. It probably contributes to their homelessness, but it also contributes to substance use. If somebody is feeling this underlying anxiety, this fear of who's behind them, it's not surprising that some of them reach for substances or get hooked on substances, addicted to substances that take away some of those feelings. A numbing is sometimes better than pain. And so in addition to the PTSD, we get to navigate substance use disorder and the behaviors and the physical dependency that can come with that. Instead of punitive judgment, acknowledging, yes, people use drugs. The person in front of you probably doesn't want to use drugs, but they're using drugs. So let's try to make that as least harmful as possible until they're ready to not use drugs. Let's make safe injection sites a thing so that people can use drugs in a safe way until they're ready to not use drugs. It doesn't increase use, it doesn't increase overdoses, it doesn't bring in new people into drug use, it doesn't increase crime in areas. This has been studied worldwide. What it does is it helps those who use drugs stay alive and engage in care, and hopefully some of them will recover. So there's a wide variety of medical, psychiatric treatments that are out there for whatever medical or psychiatric things that comes, and they've been changing in the last 5, 10, 15, 20, 30 years. And it can change some of the specifics. We had one person who had lung cancer and was on one of the new immunotherapy agents, and she got 4 years in our housing because of that. We've had patients get stabilized from liver failure, from liver cancer, and have high quality lives. In terms of psychiatric meds, the ones that are out there can help buy time so that some of that internal healing can happen, so that the symptoms can be less, and so they might be able to better manage in society. For folks with bipolar, for folks with PTSD, anxiety, schizophrenia, we can use some of these medications to help give them some of their humanity back, to help stabilize them. And yes, sometimes it'll be meds for life, and that's fine, but it's helping give them their humanity. I understand how it can be hard to sympathize with those who are homeless if all that you see are some of their behaviors or what they look like on the street. What I think is often not understood or not appreciated by the general populace is behind those worn out shoes, behind the long scraggly beard, behind the person stemming on the corner is a person, and they have a story, and they have people that care about them, whether it be their doctor or case manager, whether it be their neighbor, whether it might be their fellow homeless person who they hang out with, huddled together on the streets on these cold days. That they have a community that cares for them, and whoever's in front of you, they are a person, even though sometimes that's hard to see.
Thank you for watching this video, and we would love to share more with you. So please subscribe to this YouTube channel. For more information about all of our trainings, please visit the link below.